My topic for presentation is an unilateral best vitelliform macular dystrophy with CNVM well managed with anti-VEGF. I have no financial disclosure and conflict of interest. Best disease is usually an autosomal dominant macular dystrophy. There is a mutation seen in BEST1 gene. It is usually bilateral and sometimes can be unilateral, and in some cases it can lead to CNVM formation. Epidemiology. Onset is generally seen in childhood to early adulthood. There is an equal distribution among male and female. Unilateral cases are extremely rare, and CNVM complicates around 20 to 30% of cases. Materials and methods. Detailed case documentation was done. Recording of best correctal visual acuity. Anterior segment examination with slit lamp. Intraocular pressure measurement with applanation tonometry, fundus evaluation with indirect ophthalmoscopy and fundus photography, spectral domain optical coherence tomography, OCT angiogram for CNVM confirmation. An intraocular and electrooculogram was done to detect subclinical dystrophy. My patient was a 33 years female who presented with blurring and distortion of vision in left eye with gradual progression over 3 months. No family history of similar condition was seen. Best corrected visual acuity in right eye was 6/6 and in left eye was 6/18. Anterior segment of both eyes were within normal limits. IOP used an applanation tonometry was done, and right eye showed 16 millimeter of mercury, left eye 14 millimeter of mercury. Fundus examination showed egg yolk-like vitelliform lesion in left eye with signs of CNVM like hemorrhage, exudation, and right eye showed an absolutely normal fundus. EOG showed Arden ratio of 1.3 in left eye and 1.4 in right eye. OCT of left eye showed hyperreflective vitelliform material over macula, subretinal fluid, CNVM membranes, and retinal pigment epithelium changes. OCT of right eye was normal. Management and outcomes. The patient was treated with intravitreal anti-VEGF ranibizumab injection. The first dose was given on 22nd of February 25. Vision subsequently improved from 6/18 to 6/12 after 1 month. OCT angiogram, which was done after 2 months interval, showed some active CNVM. Therefore, the patient was given a second intravitreal anti-VEGF, which was given on 25th of April. Post anti-VEGF status, patient vision remained at 6/12 in 2 weeks. OCT, which was subsequently done 1 month after that, showed some amount of subfoveal scar over macula with no subretinal fluid suggestive of scarred CNVM. Patient was followed up at 3 months and 6 months. Vision remained stable at 6/12 in follow-up visits. Discussion. Rare unilateral presentation, this highlights variability. It helps us in identifying the stage of presentation, like whether it is pre-vitelliform, vitelliform, pseudo-hypopyon, vitelli-eruptive, atropic, or CNVM. There is an importance of differentiating it from AMD because it also manifests with similar presentations. Role of multimodal imaging in diagnosis and timely anti-VEGF regimen improves outcomes. Unilateral best disease CNVM is rare, but it is significant. Early detection with OCT and FFA is crucial. Anti-VEGF effective for CNVM management, so a good regimen is very much crucial. Advise vigilant monitoring of fellow eye for any visual decline. It can be done by an EOG to see any subclinical dystrophy if at all present. Lifelong monitoring is essential for prognosis. These are my references.